Thank you, Dr. Tay. Now, we shall move on to our first module, which is Understanding Mental Illness by Dr. Kok Sen Wai. If you wish, equip yourself with pen and papers so you can take note on today's modules so that you will not miss anything from our sharing session. Dr. Kok Sen Wai, the floor is yours.
Hi, all right, thank you. First, before I begin, I just want to ask, is everyone hearing me clearly?
Yes.
Yes.
All right, that's good. So today my module is on understanding mental illness. So this is the reason why we are all here today. I think we have a mix of people who suffer from mental illness, and we have people who take care of people with mental illness as well. So, okay, let's just hit to the question. What is mental illness? Generally, you know what we say in Malaysia, we say mental illness or sakit jiwa. It's actually a general term that we just use to describe what we call as mental disorders that are caused by some problem or dysfunction in the brain. So what does it do? You know, mental illness is something that affects every aspect of who we are. It affects how we think, it affects how we feel, and it also affects how we behave. It controls every aspect of our life, and it it makes us behave sometimes in ways that are not real, not true to us, to ourselves. So my introduction would be on mental illness in general. I'm going to be speaking on a few very common mental illness that we can see in the community. And we're going to have a brief overview of common mental illnesses, just, things that we can see. So we're going to dive in right now. The ones that I'll be talking about would be schizophrenia, then depression, and then this is actually an old term, manic depressive disorder, but right now we refer to it as bipolar disorder. There are other types of common mental illnesses as well that you may have heard of: anxiety disorders, dementia or Alzheimer's disease, which is Dr. Tay's specialty, postnatal depression, and so on. So when we want to talk about mental illness, we have, of course, a lot of, I would say, people come to it from a lot of different directions. Like, why is it so hard for us as a society, as family members of patients with mental illness, or patients or persons suffering from mental illness? Why is it so hard for us to talk about this thing? You know, a lot of people, when they talk about this thing, immediately we are afraid that people will judge us. Because when we say, oh, your mental illness, maybe you act in ways that are unreasonable, or that you are not capable of making your own decisions. And then there is also the fear that, when people around you, that is your family member, your friends, they may not be supportive, they may not be understanding. They may even say that, this is not a problem, you should just become stronger, you shouldn't see a doctor, that kind of things. Of course, people who are in a career, who has work, they are really afraid that this will affect their career. And I don't say that is something that is unwarranted, because obviously people have this, what we call stigma towards people with mental illness, and sometimes it's hard for them to see people with mental illness as members of our community who can contribute. And some people just don't want people to give them any pity, look down on them. And there are some people who believe that, if they tell people that they have mental illness, if they talk about their problems, they scared these problems will define them. People will forever say that, oh, that is the schizophrenic person, that is the depressed person, which is not something that even us in our line, we don't actually talk about patients that way. We say patients with schizophrenia, because patient comes first. They should not be defined by their illness. So all these things is quite, how to say, it puts a lot of difficulty and obstacles on people in talking about this issue. So before I moved on, I'm going to be talking about causes of mental illness. And I would like to know from anyone at all, just what do you think cause mental illness? Anyone can just, unmute their mic, just speak out.
Stress.
Hi, yeah?
Stress.
Stress, yes, stress is one thing. Anyone else? Anyone else has any idea what causes mental illness?
The environment.
The environment, true. Our environment is a big deal of our lives. So I'm going to go right into what we call as causes of mental illness. In our line, we usually think of them as predisposing factors, precipitating factors, and also perpetuating factors. And okay, it sounded like very big words, you know, but I'm going to go into them in depth, yeah. So when we talk about something like predisposing factor, we say what makes someone predisposed, makes them more likely to get a mental illness. There are a lot of things, but one of the things that we frequently see and we frequently study in our medical line is that we find that a lot of mental illnesses, they have a hereditary cause, in the sense that it's sort of how do you say, it's passed down from generation to generation. So often this cause of brain dysfunction among our patient is attributed to genes. But the thing is, it's not what we call 100%. If let's say your father has schizophrenia or your mother has depression, it does not necessarily mean 100% you are going to get it. Because someone said just now, environment is also a factor. Stress is also a factor. And this one actually affects how our genes express themselves. So this is one of the things. And in my, I've done a lot of community rehab psychiatry in my past, in my previous postings as well. So one of the things I often see is that we sometimes see a family where, there's like multiple siblings with this illness, or there are like the father has this illness, then, you know, like multiple other family members will also have this illness. It means that it's more frequently clustered around family because it makes it more frequent, but it does not 100% mean it occurs. And sometimes, you know, some people think it's something that, you know, the ancestors did wrong, it's karma, it's sometimes, again, there are some cultural beliefs that, you know, if they involve themselves in certain type of black magic, that it get passed down to generation. We see it in some community as well. But again, we do not know. I think it's always best to consult a doctor and see what's the cause there. So another thing that we're going to talk about next is the precipitating factor.
Thank you so much, Mr. Lee.
Okay, precipitating factor. So we talk about predisposing factor. So you have the genes there. What causes it to start activating? And then, you know, what actually is in the starting of the mental illness? What precipitates? What triggers it? So one of the few things we see, because you have that, what you call vulnerability already, sometimes people may have, you know, their chemistry in their brain, it's different. And this is the one way I always express, like, do you know diabetes? Like, for example, diabetes is, you know, kencing manis, right? So one of the things that causes diabetes is also genetics. And the main thing that happens is that the chemical insulin is not being produced in sufficient number. That's why some diabetic patients need to take medication. They need to inject themselves with insulin. So, but we, you know, same thing happens with the brain. When there is certain neurotransmitters, which are chemicals or hormones in the brain, which are excessive, too much of it or too little of it, then, you know, the function of the brain will actually be interrupted. You know, something that is in your body that's supposed to come out or supposed to come out a certain amount, it did not come out at the right amount, it will cause disruption. And another thing that we see in mental illness is brain damage. Brain damage or the retrogression. Retrogression is just a very fancy word to say, you know, it has become old, it has become worn down. For example, like in dementia, in sakit tua, you know, then you have those type of presentation as well. The patient will start showing signs of mental illness. Brain damage, like, you know, you have a car accident and then, you know, you have brain trauma. So sometimes that can cause some psychiatric disorder as well. There are other things, abnormalities of hormone secretion. I'm sure everyone heard of, like, you know, meroyan, or sometimes, like, after giving birth, some hormones level will have changed significantly, and that can cause something what we call postnatal depression. And sometimes if it's severe enough, it can even cause postnatal psychosis. Then psychosis meaning, you know, patient might start having problem differentiating what is reality, what is not. And in stress, of course, is another big precipitating factor. Like, if let's say you have that predisposition, even though you have the genes, if you're not put under stress, maybe you won't develop it. But sometimes if you're put under so much stress, it can start coming out. So the next thing that I'm going to talk about is the perpetuating factor. So now we have something that makes someone likely to have illness. Then we have something that causes the illness to come out. What maintains this illness? What keeps this illness keep going on and on and on until it's like chronic for months, for years, for decades? So sometimes the main thing that we often identify is just people are not getting the appropriate treatment. It's either because family member delay bringing their family member because they're trying other things. Maybe they think that, okay, maybe we try this herbal medication first. Maybe we just seek the help of this wise person first, or this BOMO, or so on. Sometimes I think it's very important, and I can't stress this enough, that one of the first things we should always think of is ask a doctor first. Always talk to a doctor first, see whether there is anything that can explain it medically. And I would say that if you treat a patient earlier, the prognosis or the outcome, like how the illness will become, is actually better. This is a concept we always talk about in psychiatry. We say, you know, the DUP, the duration of untreated psychosis. And we know that the DUP, if the longer it is, the more likely it is and harder it is to treat the person, the harder it is to get them back to where they used to be. So time is of the essence. Yeah. So now we are going more on a very philosophical, not philosophical, like, you know, conceptual idea of what mental illness is caused by. And something right now that is in the zeitgeist, right now what we are talking about, that we are thinking about, it's what we call the biopsychosocial model. And you have heard me say that how, you know, how someone with predisposition, how what happens in the brain will cause the illness and how it will perpetuate the illness. So this is all very important factors. The biological part, the genes, the psychological part, the stress, and social, like what level of engagement with psychiatry there is, like how likely it is a family member will bring a patient with mental illness to see a doctor, or they maybe will see some other person. So all of this will affect how mental illness is being treated and how it will go on. So I'm going to talk a bit about the diagnosis of mental illness and how we're going to diagnose or recognize this. So of course, first thing I must put a disclaimer. This module, even after this whole thing, you listen to me talk 1-2 hours or so, it's not something, it doesn't mean that immediately you can learn how to diagnose. But I hope at least that after listening to me, this can actually help you recognize something. Like if you look at something, you say, yeah, this looks like something that Dr. Kok said. Maybe I should ask a doctor. So these are things that, you know, you just put something in your mind. So you think about these things if this comes up. So what we believe right now is that mental illness is largely caused by imbalances in the secretion of our brain neurotransmitters. And right now, you know, if we want to say, oh yeah, if there is change in the neurotransmitters, like, can we just go and measure it? You know, take the blood out, measure the neurotransmitters, and then we can say, yeah, this person has this imbalance, this person has that illness. But that's the problem. Right now, as far as we can tell, there is no simple test that we can actually measure the level of neurotransmitters in a person, because sometimes it might not be available in the rest of the body. It's not that easy to access. Another type is because sometimes our certain other parts of the body will produce that type of chemical as well, and sometimes it will be difficult to tell, is it causing the mental illness or is it not? So generally, how we in our side make diagnosis is usually by clinical observation. We look at the patient, we also listen to the history, usually from the family. We talk to the patient, we want to know their subjective experience, what they are experiencing. So all of this is what helps us make a diagnosis. All of this is what tells us, at least make us understand where or what mental illness is causing problem for the patient. And from there, we can decide on treatment. So, okay, I mentioned this already, diabetes, like high blood pressure, high cholesterol. We ultimately see mental illness as a physical problem. It's a problem with the body. We always say, you know, the brain, the mind, it's all up here. It is part of the body as well. But the problem right now is that sometimes we always think that, you know, mental illness is like a different category, and it looks very different from other illnesses because it sort of changed how a person behave and think. So, but ultimately, it is still sort of because of an organ in our body. It is our brain. So, one of the things that I want to ask is that, what do you all think? Do you think mental illness are contagious or not? Anyone?
No.
No, right? It's not contagious. But again, dealing with someone with mental illness can cause stress. It can cause a lot of, what we call emotional burden. It cause a lot of investment, time, money, and that one can cause other, caregivers itself to get their own mental disorders. Like they can get depressed, they can get burnt out, and these are things that can happen. But it is not because it is catching. And sometimes we see it happens, like I mentioned, like many family members have the same illness. Again, it's not because it's contagious, it's just passed down through the genes. So, okay, schizophrenia. So before I move on, I would just like open to the floor. Just anyone? What do you think is schizophrenia? What does this term mean to you? There's 70 people. Anyone?
A person who hear voices, who thinks people are trying to harm them.
You are correct. There are some patients with schizophrenia who do report this kind of symptoms. Anyone else? Anyone else who has experienced or heard about schizophrenia? What do you understand? Anything. There's no wrong answer. What you see in the TV, maybe.
I think it's a severe form of mental illness with some hallucination.
Hallucination, yeah, that's a very good term. I'm going to talk about those in a short while. Yes, hallucination is something that is quite associated with schizophrenia as well. So, schizophrenia is actually has a sort of a Greek, Latin root, Schizo means it's split. Phrenia actually refers to our diaphragm, our here, right here in the belly, top of the belly here, helps us breathe, because, the ancient Greeks believed that our brain is right here. So, the term itself means split of the mind. But, but a lot of people sometimes think that, it means like split personality disorder, which is not. It is a different kind of thing. So it refers to a, function of your brain that has disintegrated. Your thinking, your emotion, your behavior has broken down. So sometimes, as I mentioned, there's a loss of reality orientation. You might have heard of the term loss of reality testing. They have trouble telling what is real, what isn't. Because, right now you're listening to me talking. Very clearly, you can hear me, my voice, what I'm saying. And sometimes when you have hallucination, for example, as mentioned by someone just now, it sounded exactly like someone is actually talking to them. And to them, it sounds exactly like real. So this is a very serious mental illness, and it can affect so many things. If let's say you have trouble telling what is real, what is not, you end up doing a lot of things that you might not want to do. If let's say you are capable of telling what is real, what is not. So when there's a term there, right? Lifetime prevalence. So what it means here, lifetime prevalence, is that, in your life, what's the chance of it that it occurs? It can go 0.3 to 0.7%. And it's actually quite common. And one of the numbers that we always talk about in population is always, that's 1% of the population that is having schizophrenia. In a group of 100 people, you're going to find one person who has this problem. So it is part of us, it's very common, and it's very much in our society. And sometimes we won't even notice it. So what are the characteristic symptoms of schizophrenia? We have someone who mentioned hallucination just now. And we have someone who mentioned something, afraid of people harming them. So I'm going to go through them one by one. So generally, one of the ways we talk about the symptoms of schizophrenia, we divide that into positive symptoms, negative symptoms. Again, positive does not mean a good thing always, Positive, like you're positive for COVID-19, that's also positive. But positive means it's something that is there, something that is extra, that is added to the patient. While negative is something that is taken away from the patient, something, part of the patient that is no longer there. So it's negative. So hallucination is when, like someone said, we can hear voices that no one else can hear, or we can see something that no one else can see. Sometimes we may even smell something or feel someone touching us that we all can't feel. And that is what we call hallucination. Something, you're experiencing something through your senses that actually is not happening in the physical space. But to you, to the person who experienced it, it is very real. It is absolutely indistinguishable. So sometimes when they tell you, yeah, you know, I hear this neighbor talking bad about me, even though the neighbor is like 3-4 houses away, there's no possible way they can hear. Sometimes to them, it is real. And you can't say, no lah, you're crazy lah, like that, you know. You dismissing it is actually quite damaging because for their experience, they actually hear it. Another thing is delusion. Delusion is when we have a fixed, you know, false belief, a belief of something that, you know, is not in keeping with what our religion, is not in keeping with what we believe in society, and it's something that, you know, you hold on so strong. Like someone mentioned, being afraid of being harmed, being hurt by other people. That is what we call a persecutory delusion. And sometimes, you know, if you have experience with patient with delusion, it's, you know, very, very, very hard to convince them otherwise. I have one friend and patient actually. He was, we did our housemanship together. You know, housemanship is our internship in medicine. He was actually diagnosed with schizophrenia in his second year, which is a very sad thing because, you know, he's a doctor, he's going on with his life. He's actually quite brilliant. But because of that, he started, you know, being afraid. He's believed that, you know, the government is watching him, and he ran away from his workplace. He ran away across Malaysia to multiple states before they found him. And one of the delusion that he has also, that he believed that his housemate has sexually assaulted his girlfriend. And I sat down with him, he's absolutely certain it happened. And even when I called his girlfriend to tell him, yeah, you hear your girlfriend, what your girlfriend said, see whether it's true or not, ask your girlfriend. And then the girlfriend said, no, no such thing happened. And after we put down the phone, he will say, actually, maybe because the housemate is there, forcing the girlfriend to say that thing. It's sometimes, like I said, you cannot, even you give them proof also, it is already stuck in that way. So that is what we call a delusion. And then we have, of course, thought disorganization. Is when the thinking becomes so messy, you know, it doesn't come out in like a very, how to say, in a very orderly way. We have patients who have thought that are very disorganized. They do things like, sometimes they do things that doesn't make sense. They take off their clothes. They will start drinking water from the toilet. They will just pick up rubbish and try to lick them. And these are because their thinking is so very disorganized. And when you hear them talk, you find that it's sometimes very hard to understand what they are saying because, you know, the thing they're thinking is not coming out in an orderly way. So those are positive symptoms. And those are things that I think every one of us can start recognizing. If you can see this in our loved ones, in our friends, these are signs that, you know, a patient may have psychosis, possibly they may have schizophrenia. The negative symptoms actually is also something that I think we can see as well in certain patients, like when they become very expressionless. You know, usually when we talk, we have a lot of expression. We smile, our eyes widen, you know, we narrow our eyes when we're suspicious, we grit our teeth when we're angry. But patients with schizophrenia, they tend to have like a, you know, very little emotion. They may have feeling it inside, but they're not expressing it on their faces often. So, you know, sometimes I hear one family told me before that, you know, because the mother always say very nasty things, very critical things towards the son who has schizophrenia. And when I said, you know, aren't you worried that you might hurt his feeling? He said, you look at him, he doesn't seem to feel anything because the face seems to be just like that. But, you know, when I actually talk to the patient, he will tell me, yeah, I actually feel very sad and upset when my mother talk about me that way to other people. So, again, this sometimes will actually cause a lot of pain in the family, cause a lot of pain in how, you know, the family dynamics work. Because I think family is very important. I think I will speak a little on that in a while. The other thing we'll say is a poverty of speech. You know, poverty, you miskin, you don't have the thing. It's lack of that thing. You find that they talk very little. And when they talk, maybe they say one word, two words. And some of them, when you talk to them, they just look at you and they have nothing to say. So that's a loss of, you know, expression in speech as well. And that's also a loss of motivation. Like when we want to do anything, we want to go out, go to a market, go to work, we all have to be motivated. Yeah, I'm going to do this thing. But patients with schizophrenia, they sometimes don't feel that drive anymore, or that drive has become so weak. So they don't feel like they want to go to work. They don't feel like they want to do housework. They don't feel like going out or meeting friends. All of this is part of it. They have lost an important part of their motivation, their drive. So again, this is just the same slide that I've described just now. It's an illustration. So we're going to just skip on ahead. So we mentioned just now what hallucinations are, but I would say one thing to take home from this slide here is that auditory hallucination, hearing of voices that no one else can hear, that are new, that no one else can hear, that is not actually sound that is happening, is actually the most common type of hallucination in schizophrenia. If you watch TV, like you watch A Beautiful Mind, you see Russell Crowe, his John Nash character, you know, the Nobel Prize winner, he has schizophrenia. You start seeing, you know, random FBI agents and all those things. But usually that is actually very rare. Not say very rare, it's just less common compared to like hearing voices. And in fact, if I understand correctly, John Nash himself never actually has any visual or things that he can see that are not there. What he had is actually auditory hallucination. And it has, you know, a bunch of types of hallucination. I don't think I'm just going to bother you with the specifics here, because I think this is a bit too academic. But, you know, they say that it can be people talking to them. It can be hearing a bunch of people talking about them. It also can be something that, you know, a voice just commenting on what they're doing, like, oh, now I'm going to pour this glass of water, I'm going to the toilet. A voice is giving a running commentary. So the thing that it is they always, it's not a voice just inside the head. It's not something in my heart. Suara hati, all that is not hallucination. It's something, the sound is coming from external space. It's coming from somewhere around us. So that is what hallucination is like. And sometimes it can be very like elementary. This is something what we call elementary hallucination. Some people may just hear whistling sound or baby crying sound. They are very common in Meroyan. They'll say that, oh, I hear baby crying when there's no baby crying. Also, you hear sounds of machine, some of, you know, things that doesn't actually have meaning, but it is constant, it is bothering them, and it's very elementary and simple. So one thing is very important. Sometimes even us normal people, if we are tired or we are about to fall asleep, or if we had, you know, maybe we went out drinking or something, sometimes we may hear things that are not there. Sometimes we even look around, hey, someone called my name. We look around, we cannot put, no one actually call our name. So those things actually can occur. Like when you're sleeping, then suddenly you hear a loud banging sound and you wake up, but there's no loud banging sound. We normal human beings can have hallucination as well. It's actually quite common. All of us have experienced this kind of symptoms. The only thing is that's abnormal is because patients who have hallucination is just persistent. It is very well formed, it's constant, it happens almost like, you know, very frequently till it affects their life. That's when it becomes an illness. So sometimes it can be very bothersome. I have patients who say that, you know, it's voices that are just saying bad things about me all the time. This voice saying I'm stupid, this voice saying I'm useless, this voice saying I'm ugly, just keep saying non-stop like that. It can be very bothersome. Or worse still, you know, some people may feel threatened. A voice is saying, I'm going to come and kill you. I'm this ghost, I'm this spirit, I'm going to haunt you. I'm doing this to your family. This can make a person very, very distressed. So when I mentioned a bit about delusion just now, right? As I mentioned, it's a fixed false belief. So it's based usually on something that you believe about reality that is not true. And usually it's not consistent, like I said, with the patient's cultural background or political ideology. So which is why we always say cultural is someone believe in, because not every time everything we believe in is something that we can see, something we can experience. Sometimes it's just a religious belief that everyone around us have. But one of the ways that someone tell me this joke that, you know, if you talk to God, it's normal, but you start hearing God talking to you, then maybe you want to see a doctor. So that's one of the things that I always in my mind when my instructor taught me about having mental illness and delusions and so on. So there are multiple types of delusion. Someone mentioned just now is paranoid or persecutory delusion. Someone is going out after you. But we have some patients with a grandiose delusion. They may believe that, oh, I'm a king, or I'm related to Siti Nurhaliza. I'm in talking terms with Bill Clinton, the ex-president of the United States. So these are all what we call grandiose delusion. They may believe that they have a lot of money, when in fact they don't. That's another term there, erotomania. It's when we have this delusion that someone is in love with us. Or, you know, we have this special love connection with a celebrity or woman in our neighbor. And that's, you know, this belief of a romantic relationship that does not exist. And very commonly, we have patients with jealousy, delusions of jealousy. we call that Othello Syndrome, you know. They believe that their wife or their husband or whatnot is cheating on them. And again, just because sometimes when we ask the patient, say, oh, I'm very sure my husband is cheating on me. I'm very sure. We ask them, you know, how do you know? I say, I just know. But when we ask the husband, the husband actually is cheating on them. But it doesn't mean if a delusion is correct, it doesn't mean that it's not a delusion. We have to always see how they come to that delusion. If they say, oh, I just know, it come to me in a dream, a bird came and told me, then maybe it's still a delusion. Doesn't mean it's true, mean it is not a delusion. And sometimes there are very, you know, bizarre delusions that we know that is absolutely cannot be true. Like there are snakes living inside my body. There are aliens walking around in Queensbay Mall, for example. And, you know, these are beliefs that, you know, we all know that it's absolutely very out there. No one believes this. No one else would believe this. So this is what we call a very bizarre delusion. So, of course, we have talked about hallucination delusion. So one of the things that we want to worry about, because those big symptoms, obviously, they are very obvious, but there are some symptoms that are more subtle. They are less easy for us to sometimes see. Even sometimes for doctors, it's hard, and sometimes we may even miss it sometimes. So mood symptoms are actually quite common in patients with schizophrenia. They may feel, you know, elated, more happy than usual. They may feel depressed, and patient may have what we call cognitive deficit. Cognitive deficit is like when our brain power, the way we think, the way we solve problems, our memory and all these things, these are all cognitive, our ability to think. So we have a lot of patients over time, their cognitive ability will actually go down. And because this will ultimately affect how they study, it will affect their ability to work, affect their ability to participate in society. So this is one of the things that we are very concerned about. In fact, if we look at schizophrenia, the name, the illness, it used to be known as dementia precox. It's something, you know, it's a precocious dementia. It's, you know, young person starting having dementia. So we can see how the thinking is. We have recognized from a long time ago that schizophrenia will cause a problem in our cognitive function. And here's a big term here, co-morbidity. So I'm just going to ask, just randomly, apropos of nothing, what do you think co-morbidity means? Anyone?
They are very morbid about things.
Morbid about things. That's an interesting thing, because morbid, yes, is the term refers to that. But anyone else? Anyone else has any idea what co-morbidity means? There's a co there, you see.
Maybe correlated to the disease.
It is. I think that is quite close to what I'm thinking of. So, someone who has a comorbid disorder, it means that it's something that occurring simultaneously. It occurs commonly simultaneously with schizophrenia. We find that a lot of our patients with schizophrenia, they have substance use disorder. They may end up going for drugs, like, you know, shabu, ice. They may, and a lot of them will pick up smoking, and they'll smoke like 2-3 packs a day, just sitting there smoking every day. And which actually gives us a bit of a headache, because, you know, it's not good for their health. It affects how they process their medication, how their body react to the medication. And some substances like ice and shabu, it can make them very aggressive. It can cause them to have a psychotic episode. And a lot of our patients, when we admit to you know, Jalan Perak here, and previously, you know, when I worked in Kuching Hospital and all that, a lot of the patients we admit actually came in because of aggression linked to substance use. It may be just because of substance, or it may be because they are schizophrenia with substance use. We precipitate that. And we always say that, you know, something we mentioned in the introduction at the start is people who are mentally ill are not necessarily violent, or more violent than other people, or more likely to be criminals. They are, though, very likely to get violence done. They are more likely to have violence done to them. But if you add in drugs, you add in all these other problems, they may become violent as well. In fact, normal people take shabu also will become violent, actually. So the other things that we often see is OCD. OCD we see commonly associated with schizophrenia as well. So anyone know what is OCD? Just jump in, anyone?
Obsessive compulsive disorder.
Yes, obsessive compulsive disorder. Anyone can tell me what does that mean? Like,
Yeah,
you,
okay.
hmm?
That means you keep on thinking about something.
Yes, it's someone who is very obsessive. They'll keep thinking about one thing, like, oh, they go out, they forget to lock the door. So they keep checking the door, you know, they compulsively check the door 20 times until they're late for work. Or they keep walking around, they must count every tile they see when they pass by. This is what we call OCD. And we see that a lot of patients with schizophrenia, they will present with OC symptoms. They may have panic disorder and also other things. A lot of them will have diabetes mellitus. They have, you know, what we call metabolic syndrome, like, you know, high cholesterol, you know, central obesity, all these problems we'll see with patients with schizophrenia. So, and one of the most important thing that we're going to talk about right now is we always think suicide. Suicide is something that we associate with depression, we associate with, you know, stress, but suicide itself is very common in schizophrenia. So up to 20% of our schizophrenic patients will attempt suicide at one or more occasions. Then 1 out of 5 of our patients would have tried it. And 5 to 6% of our patients eventually do die by suicide. And it can be very compulsive. You know, I have a patient who was in Miri. He went up to a very high building and he jumped. And why? Because a voice tells him to, and he can't avoid it. And sometimes they may have believed that they can fly. They just jump. Or they believe that, you know, there's something in their body. So they take a knife and then they cut it out and they kill themselves. This thing can happen. And which is why it's very important that we help to treat their illness before it gets to that kind of level. So this is, again, some numbers. I don't think you need to think about it too much. All it means is that if, let's say, you have family members with schizophrenia, you're more likely to have it. And one of the reasons why we know this is we do something called twin studies, like, you know, we call it identical and non-identical twin. And you can see the dizygotic twin, it means non-identical or fraternal twin, is only like 12%. But if, let's say, a monozygotic means the twin is like a clone of a person, your genetics is 100% alike, that's half the chance that the other person will have it if one person has schizophrenia. So this is something that we just want to take home. Just remember, this is a cause. So we talk a lot about what is schizophrenia. So I'm going to talk about the cause of schizophrenia. So I'm going to ask you all, what do you all think? How long do you think a patient with schizophrenia will be ill for? Few weeks, few months, few years?
Yes.
Years, yeah. That is very true. So we have some numbers, just that studying of our patient alone, we know that it can come at a very early age, especially in males. It can come at 15 to 25 years old. In female, it's slightly later, 25 to 35. And very rarely we see people that come after 45. It can happen. It has what we call late onset schizophrenia. But again, it is very uncommon. And we have to think about other causes of those symptoms that we see. But generally, you see them in the C15-25, school going to start working, or university age. These are the time when we start to see them decline, when we start to see the symptoms start coming out. And even before then, we will have like what we call prodromal here. There's a term called prodromal. Even before they become like obviously ill, before they start hearing voices, they will have these symptoms that are already there to begin with. Maybe they start becoming, withdrawn. Maybe they don't talk to people so much. They stop making eye contact. Some things that are taking, it gives us a bit of a clue, but usually it's very hard to tell. It might be just someone being, upset, or maybe they just change, like as they grow up, their personality is a bit different. But it's always usually after the fact that we realize that, oh, this patient has been like this before he became ill. So we have what we call a cause of illness. We have patients that start, what we call acute episode, something that's very obvious, something that happened. Like, a patient just started suddenly this past few months, start talking to himself non-stop. This is what, what we call an acute episode. And then after we treat them, they may have, sometimes residual symptoms. They may still hear voices, but it's not so loud or so troublesome. Then they may go into partial remission, still have symptoms, but yeah, they're getting better. And we have patients who are in remission, who no longer have any symptom. And then the next phase, of course, is recovery, when they can actually go back to their work, they can go back to their studies, what we call a recovery of function or functional recovery. And then finally, we have relapse. Relapse can occur after that. And even sometimes with patient on medication, they can still relapse. And all we can do is actually reduce the amount of time it takes before he relapses. We can reduce the severity of the relapse. Sometimes we can prevent it as long as possible. But again, there's a high likelihood that someone who has the illness, they will relapse again. And one of the things that I do when I counsel my patients and family members is that, this is not something that it's not a sprint, it's a marathon. It's a long, long journey. And sometimes it's good to have a preparation. Like in your mind already, you think that this is not going to be something that is easy to handle. It can be handled, it can be managed, but it's not easy. And I'm not going to suggest that it is. Even I, from my point of view as just a treating doctor, I can see that it has put a lot of toll in my patients' family members and on the patients themselves. So a lot of things can happen, You see, like we can have patients who started to have loss in quality of life. They can, start using drugs. They may try to harm themselves. And on the family side, we may have a lot of, increase in burden. We have family members who previously, like a parent is working, they have to stop working to take care of this person at home. And because this one illness does not affect just one person, it affects the whole family, affects extended family sometimes. And sometimes it can occur where violence occurs, whether it is the patient to the family member or the family member to the patient, because there is a lot of anger and frustration that comes out of this sort of illness. And to the public sometimes, if let's say a patient is not treated well, they may end up what we call being a public nuisance. They may do something outside that is out of their control, and we can't blame them for it. But it will cause some trouble for the community. They may end up committing some crimes. Maybe they assault someone out of some belief. Maybe, oh yeah, the voices say that neighbor is actually coming to kill you soon, so you probably have to go there and hurt him first. And then a lot of them may end up in imprisonment, because if they end up acting in a way that breaks the law. So now we are going to treatment of schizophrenia. And I'm going to just ask, what do you all think is the mainstay of treatment? What is the main thing we do to help treat patients with schizophrenia? Anyone?
Normally, drugs to relax them.
Drugs to relax them. Yes, we have drugs to help them when they are, agitated or so on. But we have medication. Let's just put that under medication. Anyone else think that there's any other thing we can do for patients with schizophrenia?
Talk to them.
Talk therapy, yes. I think a big deal of it is that we always see psychiatry as, we give medication and medicine, but actually a large part of it is talking. Not just talking to the patient, we talk to the family members. Sometimes even we talk to the neighbors or family member of the patient when we go for visits. That it is important to engage everyone, what we call psychoeducation. And right now, what I'm doing right now to everyone here is what we call psychoeducation. That we are just talking about these things. We just, no matter, even we don't take out, like maybe take only 10-20%, it's still helpful. And it helps that when we talk about psychotherapy and all that, when we talk, it actually helps people prepare themselves and learn how to manage their symptoms. So right now we are going to talk about treatment of schizophrenia. And of course, the main thing is to say, is it a disease of the mind or is it a disease of the body? And if you remember, I mentioned something just now, biopsychosocial. That term is a buzzword. We always say biopsychosocial. Everything. We paka liao, So when we say biological treatment, we have what we call medication. And we have something, what we mentioned just now. We'll give medication to help them reduce their symptoms. It may reduce the voices they hear that is bothering them. It may reduce the delusions, the things that they're thinking that are not true. After taking medication, some of the patients will start saying, yeah, maybe it's not true. They'll start entertaining doubts. And another thing that we do with treatment of patients is that we do something called ECT, or Electroconvulsive Therapy. And I think this is a pretty controversial topic. So I'm just going to ask right now, anyone here has any experience witnessing or hearing what ECT or Electroconvulsive Therapy is? Anyone? Heard of it, at least? Seen in TV or what? So,
Giving a shock. Giving
a shock. Why do we do that? Do you think, are we torturing the patient? What do you think?
maybe something to do with brain. How I say?
Okay. Okay, never mind, never mind. I think we saw before, like, you know, like if you saw a classical movie like One Flew Over the Cuckoo's Nest or anything, and when you see ECT, electroconvulsive therapy, like show in TV, it's always put like, you know, like those things they put on the head, like, you know, the thing that Kerinting Rambut on, you know, and then they start shocking the person, and the patient is sitting in a chair and they're tied up. It looks like torture, you know, and for a long time, that's what people think ECT is, and in fact, that is not. I myself have performed like by now countless ECTs, and sometimes we do this because when medication itself is not helping enough, or we want a patient to recover faster when they're in a state where they're a danger to themselves. We want to get them off the state faster. We give them a bit of a shock in the brain, and usually it's done with help of anesthesiologists. You know, what you call the anesthesia. They are actually drugged until they are sleeping. And if we are doing our job right, they won't even remember what happened at all. They won't feel any pain. And in fact, we give them muscle relaxant so they don't struggle. In fact, it's just what we do to patients when we do surgery, normal surgery, so that, you know, when you're dreaming or sleeping, we won't move our hands about or hurt themselves. And then we give them a little, you know, brief shock that will actually cause a seizure in the brain. And then that will help us receive, how do you say, it will help the brain receive medication better. It will help the brain to return to a more calmer state after it has received a shock. And then the therapy usually goes maybe like 6 sessions, one over 2 weeks, and so on. But ultimately, it is not the mainstay of treatment. Most of the time, we just end up using medication. ECT, we won't use unless we absolutely necessary. And in some cases, ECT can actually be safer than medication. Like some patients, we cannot give medication, we actually give ECT because, strangely enough, it can be safer. So now we talk about medication, we talk about biological treatment, biopsycho, now we talk about psychosocial. A lot of times we need to talk to our patient to help them cope with hallucination, with their delusion. We want to help them understand what's going on. We want to help them, maybe sometimes one of the example I give, you know, I have a patient who was working and said that the voices is just disturbing him at work. And, you know, we tell him that maybe you start listening to music on a walk, on an iPod and all that. And actually it helps when you can distract yourself. So one of the things we do in psychological treatment is help find strategies and ways for our patient to cope with their symptom. And then we also have a lot of things like, you know, how they're going to study, how they're going to work. All these things is part of our treatment. It's not just drugs and medication. And that's where psychosocial comes in, where all the self-care, you know, social functioning training, occupational training. Like first step, we get the patient without symptoms. Second, we make sure the patient can able to take care of themselves. They know how to bathe themselves, they know how to eat themselves, they know how to do everything by themselves at home. Then finally, social function, that they can function in society, whether it's through through learning, whether it is through education, whether they go to school, how they can behave in school, how they can be at work. These are all part of it. So, okay, we already talked about this already. One of the things that we always have difficulty coping is with, you know, like delusion, for example. How are we going to avoid saying that, you know, when someone tells us something to us that is sounded not true to us, we always say, you know, we just say we don't believe lah, you're wrong lah. Sometimes it's not very helpful. You feel like you're dismissing the patient, and sometimes they may stop talking to you because why do I talk to someone who doesn't want to believe what's going on anyway? So one of the important things when we deal with this kind of problem is that we want to avoid confrontation. It's very important to avoid confrontation. So we say that, yeah, okay, I think you actually do believe that these things are happening, that, you know, you are really afraid. We validate them how they feel because those feelings are real. No matter where they come from, those feelings are real, and they are human beings that have real feelings. So, but of course, we can talk to them. We can say, yeah, maybe it's true. Like, let's just see whether is it true or not. But again, we don't try to push them too hard, you know. And if let's say the delusions are very dangerous, if let's say they believe right now, oh, my wife is poisoning me, so I must kill her before she poisoned me to death. When these kind of delusions are there, this is very dangerous already. And actually, I would say that it's best to get medical personnel involved. Because otherwise, when something bad happens and we don't intervene in time, it will be quite bad. So if you think there is anything they believe that is dangerous, that will harm themselves, that will harm others, you must inform people you must look for help. Don't handle this yourself. You know, there are help available, so do seek them out. So treatment for schizophrenia and all that, I think medication and so on, my colleagues later will discuss in another model. But ultimately, the take home here is seek help. Seek professional advice. Go to a clinic, go to a doctor, have someone there to guide you through the process. Because anytime this thing happen at all, when a family member felt ill, when you yourself start having these symptoms, if you're in a, like you said, 20-something years old or 30-something years old, and you start having those symptoms, first thing you do, find someone who you can seek help from. So that is my take-home message for schizophrenia. So just to discuss a couple of cases, you know, that real cases that we had seen before, I just want to give you a couple of case vignettes, you know, just a snapshot of what it's like, how does schizophrenia look like. So the first case here that we're going to discuss is a patient named Siti. Name has been changed to protect privacy. She's a 22-year-old housewife. She lived with her husband in Perak. Then soon after marriage, she often heard her mother-in-law, who was living all the way in Kelantan, you know, criticizing her. Sometimes, yeah, of course, we mother-in-law stay with us, we can hear the criticism, that are normal lah. But let's say in Kelantan all the way, she can still hear the mother-in-law nagging, criticizing her, and she started believing that this mother-in-law is treating her like an enemy, is disliking her. So then recently, lately she started hearing voices of the mother-in-law saying that, yeah, you should divorce this man, divorce my son. So because of this, this has caused a lot of stress to the marriage itself. And then ultimately, the patient also started hearing neighbors talking bad about her. And then she started quarreling with the neighbors because, you know, you hear the neighbors saying, oh, this person, like, what I say, mandi pagi or something like that. Then you get angry, you want to go and fight with them. And when she tell the husband that, you know, the neighbor is saying this about me, how come you're not protecting me? The husband did not believe her. And of course, this again will cause a lot of tension in a marriage. And again, she is acting according to what is actually coming to her. This is her experience. My mother-in-law is being so nasty to me. My neighbors is being so nasty to me. My husband does not believe me. And can you imagine how much stress, how much distress she's under? And imagine if this is real. But because to her, this is real. So ultimately, she became very upset because for the husband is not understanding her. Then she returned to her parents' house. And because the husband cannot tolerate this behavior anymore, they ended in divorce. So that is why this is so important that we have to get in and manage the symptoms. Because otherwise, things like this will just cause a lot of problem in the family. Then another case that we can talk about here is Alice. She's a 30-year-old graduate. You know, women always a bit later on when they have this illness. She's a single banker. And she's hear voices criticizing her. You know, she's just had an illness, she just recovered, then she started hearing voices. But again, may not be related, it's just a coincidence. So even though she's aware the voices are not real, she could not resist, you know, arguing with them, start talking back. You know, sometimes you see people in mental illness, they talk to themselves, they're actually talking to someone who they can hear that we all cannot hear. So this actually will affect her performance at work. People see her, hey, she talked to herself, you know, something wrong there. And then because of that, she can keep making mistakes. So this is a patient though we actually managed to treat. And ultimately, after we treated, the voices actually gradually disappeared. But one thing, like we mentioned just now, one of the perpetuating factor is that poor, you know, they are not sticking to the treatment properly. And she actually stopped her medication because, oh yeah, the voices is gone, I'm going to stop it. But, you know, because she said, I don't want to be dependent on the medication. But ultimately, it actually leads to a relapse. She became ill again. And then this will happen several times. And again, every single time this happens, she's going to have more problems at work. She's going to have more problems with her family. So again, schizophrenia is something what we call chronic illness. It's a long-term thing. It's a marathon. It's something that we have to keep vigilant on. We have to try to keep treatment on. It's just like diabetes. If you take away the diabetic medication, sometimes your sugar is going to shoot up. It's going to be bad for your body. And your body in that high sugar for so long is very bad for you in the long term. You're going to have heart attack, you're going to have stroke. Same thing with schizophrenia. If you let a person become ill for longer and longer and longer, it's harder and harder for us to treat. So ultimately, when she finally agreed to continue medication, she actually can go back to work. She can continue her work as a banker. And I have multiple patients that's out there right now. I'll meet them in the shopping center. I'll meet them at restaurants. They are working. So one of the things is that, you know, when I I see them work that way and they can function normally in society, I'm very happy. So all we want actually, to be honest, is that we just want our patients to be well. We want them to be able to live fulfilling lives, to be able to take care of themselves and earn a living and just be part of society. So sometimes, you know, we have a lot of sometimes contentious relationship with our patients, because sometimes it sounds like, doctor always want to lock me out, doctors always want to force me to take medication, this medication give me a lot of side effects. We understand that, yes, the medication are not perfect. Side effects do happen. But we realize that from long experience and all that, that if let's say we don't deal with it, the result of it without medication is a lot worse. So before we move on to the next illness, again, it's not going to be as long as schizophrenia, I promise. So before we move on to depression, any questions on schizophrenia?
Can we say that most of these mental illnesses, you have to take the medicine for lifetime to maintain the balance?
Okay, that is a very, very good question. That's a very good question. I would say it depends a lot. For example, depression. In fact, in our guidelines and all that, a lot of times depression, we will say that after a person has been well for so and so period, we may eventually stop. I have patients with psychosis who somehow after they stop their medication, they did not relapse again. Again, those I would say are very rare, very, very uncommon. So whenever my patient, you know, say that, okay, I want to stop my medication right now, I will tell them, this is what is likely going to happen. Because I practice something what we call shared decision making. I'll try my best, of course, to tell the patient that, you know, if you stop your medication, you may relapse. It may come back. In a very, 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 very small chance that it doesn't, I don't want to bank on that chance. And if you fall sick again, you get admitted, you cause problem at work or at the household, those are things that you cannot repair. So I would say that there are patients who require lifelong medication. I've seen that, and unfortunately that is so. I have seen patients, a small minority, that does not need. So when you ask me whether someone will be required to be on medication for their life, my answer is always, it depends on patient to patient. We are not, you know, unfortunately, I'm not a god. I don't have any magical powers to predict. And I only can see from how each patient deal without medication. I hope that answers your question.
Okay,
but
thank
yes,
you.
Yeah.
Thank you.
So, any other
Doctor,
questions?
we have 2 questions here in the chat box.
Oh, wait, I have to turn it on. Just a moment.
No, it's one question that is not being answered.
Oh, okay. What's the question? Can you read it out to me?
Yeah. How to differentiate between schizophrenia and dissociative identity disorder, multiple personality disorder?
Okay, DID, dissociative identity disorder. So one of the things we have in schizophrenia is what we mentioned just now, all those loss of reality testing and all those things, and they may not necessarily manifest a different personality. When we say a dissociative personality identity disorder, someone actually end up manifesting a totally different person. And one of the hallmarks of someone with DID or dissociative or what we call split personality is that one identity does not know of the existence of the other identity. A person with schizophrenia may say that, oh, right now I'm being rustled by hantu. And then when the hantu sort of go away, they'll say, yeah, I was rustled by hantu just now. One of the things that people with dissociative identity disorder, they will not notice it. They will say, they will act this way in one point in time. Then after that, they'll have a different identity at another point in time. But when you ask them, okay, who's that person just now? They say, no, who's that? I have no idea who that is. They have no idea that happened. So those are some of the things that we look at. And someone with dissociative identity disorder, they will not have those, like, you know, what we call hallmarks of schizophrenia. They will not have all those, you know, hearing of voices, all those, you know, delusions necessarily. So this is some of the ways that we differentiate these two, but it gets very academic if I go into details. Yeah, but I hope at least it gives you an idea that how it looked different from the two. Okay. All right, so I'm going to move on to depression. So what do you all think depression is? What's your opinion? What do you all understand with depression? Anyone?
Everything seems negative to them.
Everything seems negative to them. What does the word depression mean to you all, just out of curiosity?
Sad, always very sad.
So have you all been depressed before? Would you all say that you have periods when you're depressed? Yeah? I think everyone would have
Yes.
those periods of time when people feel sad or down, because that's just life. We have things that disappoint us, things that happen, bad things that happen to family members pass away, moved away, or fights and quarrels, and that will make us sad. But we have to tell one thing, when we say depression has two meanings. One thing we use in common term, I'm depressed. But when we use it in psychiatry, we describe something what we call clinical depression. So depression is different from normal sadness. Normal sadness, sometimes we'll be sad. Yes, it's normal. I think everyone has to be sad. If you're not sad, I say it's very abnormal. Sometimes I get call from some of my colleagues from other department. They say, oh, I have this patient, she's crying in my ward. I think she's depressed. I come and see. I ask her, oh, how long has been crying? Oh, just this morning. I said, why is she depressed? Oh, she got cancer. I said, of course. If you got cancer and you don't cry, then I think maybe you should call me if you don't cry. But if she's crying, I think that's normal. So I think expression of sadness is normal. But when you're depression, when you just prolonged low mood, yes, associated with a lot of problems, what I call somatic symptoms, symptoms of the body, which I'll talk about later. When we have this problem prolonged for weeks and months, and it seemingly doesn't seem to abate itself, it doesn't improve, then we start to think, is this depression? So depression is very, very, very common. 4% of population is depressed. And we have a lot of what you call categories of symptoms. I look like a lot of words here, right? So it's very confusing. So there are different levels here. So we have emotion. Depression will affect emotion. Patient may be constantly feeling low. They'll be crying. Sometimes they may be irritated. They feel anxious. They lose interest, things that they like to do. You see, last time they like to go and garden. Now they stop gardening. Or they like to play games. They stop playing games. Then they feel helpless. They feel desperate. They feel guilty. All these things, they are feelings that will come with depression. And it affects their thinking as well. Remember we said things affect our emotion, our thinking, our behavior. Thinking, they become very passive, lack of confidence. They start thinking of wanting to commit suicide. Their thinking becomes slowed down. They'll say that, oh, right now I can't think as fast as I can. I feel like I've become more stupid like that. They'll describe it that way. I feel more stupid now because their thinking has slowed down. And behavior-wise, you can see that maybe they have lack of energy. They become unable to take care of themselves. They don't keep out the appearances. They don't comb their hair. They may withdraw from society and all that. And when we talk about somatic symptoms and body symptoms, right here at the bottom, physical symptoms, you see that they have either sleeping too much or sleeping too little. Normal humans sleep 8 hours a day, but they'll sleep sometimes for 12, 20 hours, they're still sleeping. Keep going to sleep. Or they don't sleep at all, maybe 2 hours a night, or sometimes the whole night they don't sleep, and they say that, and in the end, in the morning, they feel tired often. They have loss of appetite, or they sometimes eat a lot. So, some people stress eat. They have decreased sexual drive. Maybe they no longer want to be with their wife or husband. They may gain weight or lose weight in a short period of time. Then, of course, it's come with lack of eating. And they frequently have, a lot of these physical problems. Say, I have aches here. We have a lot of I feel this stomach, discomfort all the time. And always they have these low spirits. They may actually feel worse in the morning also. So these are all symptoms that will occur with someone who is, having depression. And I think if you read through this, I think everyone will have feel some of this at some point or others. But if you feel it persistently for weeks and weeks and weeks, that's when you probably think, am I having depression? Do I need treatment? So when we talk about treatment of depression, same thing. We go back to the biopsychosocial model. We have what we call psychological therapy. We have cognitive behavioral therapy, where we train and teach a patient to think in a certain way, to correct what they're thinking that may not be very helpful for them. And we try to train certain behaviors that are more helpful for them. This is what we call cognitive behavioral therapy. We have interpersonal therapy, where we, dealing with other people. We have teaching of coping skills. And any psychologist or counselors would know will help you with these things. Then, of course, medication. Does anyone know any names of any antidepressants, any medication we use for depression? Anyone? Very popular in movies, they always talk about it, like Prozac, Zoloft. We all heard of these names, right? Prozac, Zoloft. We have those in Malaysia as well, and we have more than that. Those are actually quite old already. And then ECT, our old friend, we mentioned ECT just now. Sometimes we have patients who are so depressed that they stop eating. They're just starving themselves. They just have no appetite whatsoever. or they just have so much suicidal thoughts. They keep thinking of committing suicide. Every other day they cut themselves, they do something, they try to hurt themselves. And sometimes ECT, we found after we giving them a course of ECT, those symptoms, they start eating again. They also will stop having so much suicidal thoughts. So ECT is something that we give again when it's a very, very, very severe level of depression. But before that, we have medication and psychological therapy. So that's depression.
Hello.
Yeah,
You don't mind? Can I ask you a question on the depression?
Sure. Go
Right.
ahead.
So there is a person who I know went through a bad time,
Right.
and apparently did a big blunder in the person's life. So kindly, I mean, I'm trying to help, but then again, she says that she's feeling suicidal, and there are times you feel, oh my God, it's me to blame, etc., etc. But the thing is that even though we try to seek help for her, she seems to be still happy going around, and she says that she can't sleep, and she's been taking some medication for sleep, and she says that she's been given some medication on her depression. So, but she goes around still able to function. Like you see her, she's still happy, but she's trying to avoid the issues or talking about the problem. How do you actually convince this type of person to seek help? Because she seems to be not herself, because her happiness doesn't seem real. Maybe it's because of the medication. Do you think it's because of the medication she's been prescribed?
Okay. Well, let me understand one thing here. You said she has sought help, right? That's why she got her medication?
I think she has spoken to her normal GP.
Normal GP.
Yeah, that she says she's can't sleep and she's feeling depressed. And then she did tell us that, yeah, she's been taking some pills.
Okay.
But I don't know what it is.
Okay. I have to put a very strong disclaimer here first. This session is not, I can't do any consultation over this.
Correct.
One thing is illegal. I can't do that. So ultimately, we still have to, because you know her better and what things going on, ultimately, I would say you have to convince her to go to a doctor ultimately. Someone who is more like, not a normal GP, maybe someone who is more in tune. Because there are a lot of things that we want to be worried about. It may not be depression. It may be something else. And sometimes it's just, again, impossible for us to tell, for me to tell, for example. So, which I think, like you said, sometimes people may feel very extra happy and all that. It might be something else. Like I say, this superficial happiness, it might be a front they're putting on you, or maybe they are really happy. I have no idea. So I can't really give a lot of advice here.
But for those,
sorry,
I understand. But for those who have mental issues or have some sort of problems, because I faced it at the workplace as well, they, of course, they don't tell them. There are a lot of them are in denial, right? And you say, can you go and seek help? Can I help you to seek help, right? But they seems to say that I don't have a problem. Okay. Now, how do you convince people to seek help or get help? Do you have to go through family members? Do you think?
Yeah. Here's my position on this. Ultimately, I believe in patients' rights. And even to the right where if they definitely do not want to seek treatment, I don't think we pushing them to seek be very helpful. They may not ultimately be cooperative with treatment as well. So I would say the best position is, make sure the person has good support system. If let's say you feel comfortable enough talking to their family, just discuss, do you think this is a problem to the family if you want to? And most importantly, be a friend, always be available. Tell them, you can talk to me anytime, reach out to me anytime. I would say best is just to be available, but ultimately we can't force people, This kind of things is a bit hard.
All right, thank you.
All right, thank you.
Thank you.
So the next one, the final one, short also, is going to be on bipolar disorder. So I'm going to ask everyone right now, what do you all think? What's bipolar disorder?
They have very strong mood swing from...
Strong mood swings, okay. That's one way of describing...
Unpredictable mood.
Unpredictable mood. Okay. So bipolar disorder, I think, is one of those things that we have a lot of misconceptions on. Because sometimes we just say it's they swing up and down a lot, but usually it's not that far, like it's not so much like, oh, one day is like this, then the next day is like this, or hour to hour it changes a lot. That is something else already. Bipolar disorder is a bit more, but let me see. Let's just go in and see what it is. So as I said, it's used to be known as manic depressive disorder. Winston Churchill, they say that they used to have this illness. But again, this is historical. but we know like actually a lot of movie stars have it as well. Like Stephen Fry from the UK, he has bipolar disorder and he's very open about it as well. So there is a fluctuation. A fluctuation is true. It does go between what we call a manic state to a depressive state and so on and forth, because it's a cyclical mental illness. Goes up, goes down. But, and actually there are, it's not so simple as just an illness. There are multiple concepts of it. We have, for example, bipolar 1 disorder, bipolar 2 disorder. But again, too academic, I'm not going to go into it. But the changes isn't so fast. It may be, patient may be manic for days, a week. Then after that, they may be depressed. They can be depressed for months, 5, 6 months. Then again, they have a manic episode. I have a patient who would, you know, go from like having a manic episode, very high, very happy and all that. Then suddenly for years and years, it's just sad, depressed. Like 5, 6 years, then suddenly they have another manic. So most of the time, it seems like my patient, this is depressed. So it is not as simple as, you know, it just goes up and down. It is something that is a very long, prolonged kind of illness. So one question I'm going to ask you all, what do you all think? Like, do you think when a patient with bipolar, are they more usually very manic or are they usually very depressed? What do you all think? Anyone?
More depressed.
True, that is very correct, because most of the patients with manic depressive disorder, with bipolar disorder, they spend most of the time in depression, to the level that when we see a patient with depression come to us, we always check, is there a manic episode in the past before? Because it's very easy to miss bipolar because it just looks like depressed most of the time. So here's one of the things that, again, is very messy, it's probably hard to tell, but you can see it right now. Can you see the cursor, right? So this is what we call our mood baseline. This is how we usually feel, you know, our neutral feeling. And then we have levels that goes up to a level we call hypomania and mania. These are different levels of feeling very high, very happy, very elated. And then below this line is when we're feeling low, we're feeling sad. Someone who is having depression, when you say if someone has a depressive episode, it's not like just 1 day, 2 days you're sad, means you're depressed. Usually depressed episode, it takes at least 2 weeks. You see here? It takes at least 2 weeks before we say this person has a depressive episode. Meanwhile, someone will have to have like mania or manic symptom for about a week before we say, yeah, this patient has mania. Or 4 days with certain levels of symptom that we say this is hypomania. It's mania, but it's not so serious. Mania, you already need to be in the hospital already. You need to be treated already. Hypomania, still not that bad yet. So when we talk about bipolar, we talk about depression already, actually. So all these symptoms actually is the same as depression. We talked about it earlier. But I want to talk about mania, manic episode. So when we have patient with mania, they will have very high, overly excited emotion. You know, they sometimes like they're just very cheerful and all that. But again, subset of patients, especially those with bipolar 2, they tend to be very irritable. They tend to have a lot of easily anger. You say a small thing, they get angry. You make a bit of noise, they become angry. And then sometimes we see that they have very poor concentration. They will have become, you know, very excited. They have exaggerated thoughts. They feel like inflated sense of self-importance and self-confidence. They'll say that, yeah, I can do this. I'm actually the smartest person. I can definitely do this. Like I can do, I can repair computer even though they have never done it before. They don't know how to do it. They go and do it anyway because they absolutely certain they are able to do it. And if it becomes so bad where they start thinking that, oh, actually I can drive an airplane when they don't know how to drive an airplane, or you know, when they say that I can go to see the Agong because Agong is my nephew or what, then it became a delusion already. And again, we see that word delusion, not just schizophrenia. Delusion can occur in bipolar as well. This is what we call a grandiose delusion. They may believe they have like, oh, I have houses everywhere in Penang Island. I have this mansion and Bukit Jambu and so on. But you know, actually, this is just a belief that is wrong. And they believe it because they feel so good about themselves. Obviously, I'm so good. Obviously, I should be this rich and should be this well connected. So they may see that they'll start talking a lot. They become very talkative and they talk so much that it's sometimes very hard to interrupt them. They just want to listen to their own voice. They want you to listen to their voice. They speak loudly, nervous. One of the things they see, they start spending a lot of money. They think they have a lot of money. They go and buy a lot of things. They buy a lot of things that are useless. I buy 10 pairs of shoes suddenly. This is lavish spending spree that we see in patients with bipolar. And they are also prone to having impulsive decision making. They'll make unwise commercial decisions. Like, oh, I'm going to put this much money, invest in this. I'm going to buy this new car. Suddenly, they just do a lot of impulsive things that doesn't make any fiscal sense at all. And overall, in their body-wise, we start seeing that, they stop wanting to sleep. This is different from cannot sleep, They actually say that I don't need sleep. I have so much energy. I think I sleep 2 hours. I already still feel very fresh. I still can think very well. And they will have increased sexual desire. Their libido will increase. They have increased appetite. But, but actually they end up, some of them actually have decreased weight because they're so active. So this is what we see in patients with mania, in manic episode. And of course, something that is less, less severe than this, what we call hypomania as well. So in this two sides, we decide whether a patient, if they reach mania, we say this is a type 1 bipolar. If let's say they do not reach mania, they only hypomania, but they have most of the time they're like irritable, they're low mood, they're mostly depressed, we say they are type 2 bipolar. So same thing, treatment of manic depressive, of bipolar disorder is medications. Mood stabilizers is the mainstay, and we use a lot of medications for that that is available for us to help stabilize their mood. The other aspect, of course, psychological counseling. They need to be educated about their illness. They need to identify, for example, early warning signs. Say, oh, maybe if you start thinking of wanting to have a lot of business plan, you start to have a lot of business venture, you try to want to buy a lot of things, or you start seeing that maybe you talk a bit more and you don't sleep so much, maybe that's when they have to identify, okay, maybe I'm going into mania again. So time for me to talk to someone, talk to my doctor, maybe adjust my medication. So this is important. And then, of course, a lot of problem with bipolar is their rhythm is completely out of whack. They are not sleeping. They're doing things that are not in the right time. So one of the things we do is called interpersonal social rhythm therapy, where we get them to have back to a normal rhythm of life with both sleep, eating, and so on, which will actually help as well. So that is bipolar. But before I end my part of the module, I just want to ask everyone, do anyone know who this is? This person in the picture?
Yes.
So who's that? Who's that?
Van Gogh.
Van Gogh, yes. This is Vincent van Gogh. Very famous artist. I'm sure you all seen his biggest hit, The Starry Night and so on. Vincent van Gogh is someone who suffered from psychosis, from mental illness all his life. At one point, he actually cut off his own ear. So it's quite severe. But at the same time, he is still capable of producing, art that we still appreciate to this day. And he's not a person who is capable of selling his art. He's not a person who is capable of marketing his skills. And the thing is, he managed to do all these things is because from the support of his brother. And I always find it one of the most touching stories in psychiatric history is that the brother is the one that makes sure he's well, even though that time they don't have the proper medications for him, that's not as good as what we have now. He still managed to get him to have a relatively well-supported life. He's loved and he's able to perform his art. And I think this is a very important take-home message we have for everyone here, is that love and support is very important to anyone with mental illness. And it is something that can actually help them flourish even. And I hope that, everyone will just remember this after this session, yeah? So it's okay not to be okay. And it's important that we start talking about it, yeah? All right, so that concludes my presentation. Does anyone have any more further questions? All right, if there is no further questions, I'm going to pass this on to back to the presenter. Thank you.